This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026. It's a meta-analysis comparing robot-assisted versus frame-based stereoelectroencephalography, or sEEG, electrode implantation in patients with drug-resistant epilepsy.
This is a timely discussion, Ilara. Epilepsy remains one of the most common chronic neurological disorders, affecting roughly 65 million people globally. And while we always start with anti-seizure medications, about 30 to 40% of our patients just don't get adequate control.
Exactly. For those patients with focal drug-resistant epilepsy, our goal is surgical intervention to achieve seizure freedom, but that hinges entirely on accurately identifying the epileptogenic zone, or EZ. When the non-invasive workup, the MRI, the PET, the video EEG, doesn't give us a clear target, we have to go internal.
Right. We've been using sEEG since Talarak and his colleagues introduced it back in the 1950s. It's the gold standard for mapping these networks, especially for deep structures like the insula or the cingulate gyri. Historically, we've always relied on frame-based stereotaxy, or FRS. It's served us well for decades.
It has. But as any resident who has spent hours in the OR can tell you, FRS has its hurdles. The paper notes that frame-based systems can be ergonomically challenging. You're often limited to linear or orthogonal trajectories, and the setup and manual calculations take up a significant amount of time.
Which is why the shift toward robot-assisted systems, or RAS, has been so massive. Systems like ROSA or Neuromate are becoming the new norm. This study by Abbas and colleagues really tries to settle the debate. Are these robots actually better or just more expensive?
To answer that, they conducted a comprehensive meta-analysis following PRISMA guidelines. They looked at 8 retrospective comparative cohort studies involving 758 patients. They focused on 3 pillars: accuracy, efficiency, and safety.
Let's start with accuracy, because in the EZ, a few millimeters can be the difference between a successful mapping and a missed target. What did the data show?
It was actually quite reassuring. The meta-analysis found no significant difference between robot-assisted and frame-based sEEG across any of the major accuracy metrics. Specifically, they looked at depth error, where the mean difference was 0.24 millimeters, and radial error, with a mean difference of only 0.07 millimeters.
And what about the entry and target points? Those are usually the metrics we scrutinize most during post-op CT verification.
Same result. For the entry point error, or EPE, the mean difference was minus 1.35 millimeters, and for the target point error, it was minus 0.02 millimeters. Both had 95% confidence intervals that crossed 0, meaning neither technique was statistically superior in terms of spatial precision. The robot maintains that sub-millimetric accuracy we expect from the frame.
That's a vital point for the residents listening. Even though the robot feels more high-tech, the gold standard frame is still just as accurate. The robot's advantage, then, must lie elsewhere. Let's talk about efficiency, the workflow aspect.
This is where the robot really shines. The study found that robot-assisted sEEG demonstrated a significantly shorter overall operation time. We're talking about a mean difference of 32.58 minutes saved per case.
32 minutes. In a busy functional neurosurgery suite, that's huge. It could be the difference between getting a second case on the board or not.
And it gets even more granular. When they looked at the operation time per electrode, the robot was 6.55 minutes faster per lead. If you're implanting 12 to 15 electrodes, which is common for complex mapping, those 6 minutes per electrode really add up.
I find it interesting that the paper mentioned pre-implantation time was comparable between the two groups, a mean difference of only minus 1.46 minutes. So the time isn't being saved in the planning phase, but in the actual execution inside the OR.
Exactly. The robot allows for greater planning flexibility, including complex, nonlinear, and oblique trajectories that aren't restricted by the orthogonal coordinates of a frame. Once you're in the OR, the robotic arm moves to the pre-planned trajectory automatically, which bypasses the manual adjustments we have to make with the frame's arc and run.
It also mentions that the electrode number per patient was comparable, about 0.86 difference. So it's not like the robot surgeons were doing simpler cases with fewer leads. They were doing similar work, just much faster.
Now, let's touch on safety. For any new technology, the first question is it safe? The meta-analysis looked at overall complication rates, including hemorrhagic events, neurological deficits, infections, and technical complications.
And?
No significant difference. Both techniques demonstrated comparable safety profiles. Whether you use the frame or the robot, the risk of a major hemorrhage or infection remains statistically the same according to these 8 cohorts.
That's an important takeaway for the attending surgeons. The shift to robotics doesn't come with a learning curve penalty that compromises patient safety, at least not according to this meta-analysis of over 750 patients.
To summarize the findings for our listeners, Abbas and colleagues concluded that robot-assisted sEEG significantly reduces both overall operation time and operation time per electrode. However, when it comes to the actual accuracy of reaching the target and the safety of the patient, the robot and the frame are essentially equal.
It's a classic case of technological evolution. The conceptual foundation of sEEG hasn't changed since the 50s, but the tools have. The robot offers that maintenance of sub-millimetric accuracy while providing a faster workflow and greater planning flexibility.
One thing I noted in the paper was the mention of 3D reconstructions. The robot-assisted systems make it much easier to generate accurate 3D reconstructions of electrode paths, which helps in avoiding vascular structures during the planning phase.
Absolutely. For the residents, remember, the goal is the EZ, the brain region whose resection results in seizure control. Whether you use a ROSA, a Neuromate, or a traditional stereotactic frame, your focus is on that precise localization.
This meta-analysis really helps justify the investment in robotic systems for high-volume epilepsy centers. If you can save half an hour per surgery while maintaining the same safety and accuracy standards, the efficiency gains are undeniable.
Well, that's a deep dive into the 2026 Abbas meta-analysis. A big thank you to our listeners. Hopefully, this helps you the next time you're discussing sEEG planning in the clinic or the OR.
Thanks for joining us on the Neurosurgery Hub podcast. We'll link the Acta Neurochirurgica article in the show notes.
Until next time, I'm Dr. Aris.
And I'm Dr. Alara. Keep learning.